you say, and there's a lot of people out here waiting for the answer to this one, what do you say to patients who have PPMS who would like to consider HSCT?
Primary progressive MS?
Yes.
So I don't do them. I don't see them. I don't do it.
I'm sorry, what's that?
I don't offer transplant for people with primary progressive MS. My bias is primary progressive MS is a different disease than relapsing remitting MS. So it's called
That was
MS.
my next question, because I went to a conference of Dr. Sadiq's of Tisch a few years ago, and he very clearly stated that he believes PPMS is a completely different animal than MS.
I do too. So even everything that we call relapsing remitting MS, it can be quite variable in different patients. And I think with time, we'll tease those out into different subsets as well. Because it used to be that neuromyelitis optica, or Devick's disease, was called MS. It was just it was just MS in which you had long spinal cord lesions and optic neuritis at presentation, and with little brain involvement until late in the disease. Then you get the brain involvement. But they just thought it was a type of MS, and people argued back and forth for 100 years, whether it was different. But now we know it's different, that neuromyelitis optica is due to an antibody to astrocytes, an antibody to aquaporin-4, a sodium water channel receptor in these astrocytes. And you don't see that in MS. It's specific for neuromyelitis optica. And, it's much more rare than MS, but it also tended, to be, you could tell by the MRI of the cord there, the lesions tend to be 3 vertebral lengths long, 3 vertebral bodies continuously in length, whereas in MS, it's always less than 1 vertebral body, unless they become confluent, then it looks long, but it's just there's so many they're confluent. And it also is very common in the optic tract, well, so is MS, but it's just much more common with neuromyelitis optica. So people were kind of diagnosing it clinically, and then eventually with the discovery of the aquaporin-4, it's now clearly a separate, distinct disease than MS, but it's a CNS demyelinating disease like MS, that is, affects the brain and spinal cord, but it's different. So I think with time, you'll see some MS patients have all these lesions and yet not much disability. You'll see some with a few lesions, a lot of disability, and it's not the location in the brain. The MS behaves differently in different people. There's going to be different pathophysiology, but within the relapse remitting, fortunately, this HSCT works very well. It appears to be all kind of immune mediated. By the way, the regimen I have to use for Devick's is different. Cytoxin ATG is not enough, they'll relapse. So we have to do it differently, and that's in the book. Again, the regimens have to be designed for the disease. It's still a non-myeloablative regimen, it's just more immune suppressive, and that regimen works, but I think it's too unnecessarily immune suppressive for MS. So my take on primary progressive, 90% of people at onset are relapsing remitting, 10% primary progressive, roughly, is that that's a totally different disease up front, and it's more predominantly neurodegenerative and not immune-mediated process from the beginning. And so that's why I will not offer transplant for that, which is really an immune-based therapy. It's an immune reset therapy that's very effective, but it has to be done the right subset of patients with the right regimens. And of course, you can never make mortality 0. That's the big handicap. If it could be, I think, there'd be a lot more acceptance. But once you get that mortality really low, 0.5% or less, and people are seeing these results, and a lot of people, quality of life is really important. And if you're only looking at being in a wheelchair and no quality of life, not being able to bring in an income, that money that you do have or your family has is just being spent for a future you don't have, and you're losing who you are from MS, you look at those risk benefits, are not so bad. So that's why I'm saying these decisions have to be made by someone who is in those shoes, not by those of us who are on our sofa thinking about it. It's the person in the arena, as one of my patients said, Eritrea, that is getting their butt kicked, that really understands and knows and, has to make that decision, the patient, with given informed consent as best as we can. And I think that's why it's so bizarre that it's patients like yourselves that have had to go out and push this.
Yeah.
And it's like, so many patients say to me, well, why aren't institutions and doctors standing on rooftops shouting about this? It's like, it's so weird, it's like we've got something that really works and we have no patent or license on it. I'm not trying to get
Right.
money out of this, yet
Right.
people aren't doing it.
Right.
And I think patients find that very frustrating. I myself find it frustrating. And so I explain why that is in the last chapter. I don't think it's anybody, well, I know it's not anybody not wanting to help the patient or being, intentionally malevolent or whatever. It's the way we think and the way our systems end up being designed. And that's all in the last chapter. And with suggestions of how we could improve the system so that, more people are made aware of this and are able to get it.
What do you think? Let's say you've had HSCT, you're doing well, and all of a sudden you have a relapse. Are there certain things just from your experience that you feel could be a trigger to a relapse?
Yes, but I've never done the statistical analysis. I could be totally wrong. And so I don't want anyone to get worried or anything. It's just an
Right.
impression I have, and I don't know if it's correct statistically, but I think it's getting pregnant and then right after delivery, or if you breastfeed after you stop breastfeeding. So I've noticed a much higher percentage of relapse in that subset of people. But again, I've never gone back to analyze the data to see if this is statistically true.
Right.
But it's enough where I would want, it's enough of there's always this time delay from when you have the idea to start this field, which I had 35 years ago, and then go through animal models for 10 years and then bring it to the bedside and sit at everybody's bedside and see what's going on. And then the time to write up the data and the publications, there's tremendous delay in there, but and there's so much to do. There's so much to write. You don't know where you're going to find the time to get that done. Right now, I've got another paper I need to work on that I don't have time for. That actually has to do with my IPS work, which is what I want to bring forward.
Yes, and I want to ask you about that because for people like us, I think it's a perfect next step. But I want you to tell me that.
Back to
Sorry.
the relapse, it's enough of a sense of seeing that when a person after delivery, if they're not going to breastfeed, I'd like to see them get a few months every month of IV Solu-Medrol to try to prevent a relapse. Or if they're breastfeeding, that's okay. Breastfeeding seems to be protective when they stop breastfeeding, a few months of it. Now, whether that would help or not, I don't know. And
Right.
again, I haven't analyzed the data. And so I'm out there on very, very thin ice, and I can't in any way justify what I just said, except through my
Right.
lived life experience with patients. And whether that would be effective or not, I don't know, but that would be my bias.
So IPS, is that your new adventure?
Yes, it's new for you. It's new for the world. For me, it's not new. I've been working on that for 10 years. So I used to transplant leukemias, but I was working in animal models for 10 years on autoimmune diseases, and then I stopped cancer and leukemia totally, and I focused on autoimmune. It's probably why I got really good at autoimmune, because I totally gave up cancer. And nobody else in the world's doing that. That you have cancer doctors treating MS, but they don't know MS and they're not focused on it. And you have neurologists referring to patients, but they don't know transplant, they don't do it. So if you really want to get good, you got to focus on it. It's like Federal Express became very good at delivering packages because that's all they do. They don't deliver, a little envelope or whatever they didn't compete with post office packages. Submarine sandwich shops got really good because that's all they make is submarine sandwiches. I think people have this idea you want to diversify and make more money, and But if you really, really want to be good, you got to focus on one thing. And that's how I got successful at what I did. Albert Einstein in his 5 Rules of Life said, don't tell people how to be successful, how you got successful. But how I did is I gave up cancer, I focused on autoimmune disease. Nobody else in the transplant world has really done that. And that is how I got really good at it. But while I was doing that, I also had another idea grab my gut about a way to treat aging and degenerative processes. So like autoimmune disease is just this chronic problem. You take drugs, it slows it, but you're always on drugs and you still get worse, but you slow the worsening. So transplants really fundamentally changed that. And I figured out really good regimens for 5 diseases that I have experienced some others I haven't put in the book, where I think we could even perfect those regimens more, and I could spend my lifetime just finishing that. But 10 years ago, I had this idea of how to use stem cells for aging and regenerative, and started working on that. And that I approach differently because it's a true stem cell therapy. IPS are just where we take a adult cell and we genetically reprogram it back to the embryonic state, and then we change it subtly. So it's a universal nurse cell that repairs any organ or tissue independent of immunologic differences. So one cell would work for all of us on this conference or anybody listening. It's not going to be restricted by the immune system in any way. And it repairs, that we found in animal models, any injured organ. Doesn't matter if it's the heart or the spinal cord or wounds, or for that matter, we found we can make animals younger and we can make them more intelligent. I actually called that making them more intelligent, my Flowers for Algernon experiment, from the book Flowers for Algernon. There was a movie called Charlie based on that book. But in any event, my goal, if God willing, if I have enough time, is to bring those to patient bedside. And that's what I'm trying to do, because that's simple. Now, that's not for MS. It's not for an autoimmune disease, but it's for...
That does not include remyelination?
Well, yeah, then what it's for is for like when you're in the neurodegenerative phase for neuroregeneration or remyelination, but it could be used for any aging or traumatic process.
Spinal injury?
Yes. And in animal models, it was very effective for spinal cord injury. But what that really involves is just injecting the cells. There's no hospitalizations.
There's no chemo.
No. But getting there, that's a whole, to do that, we've got these 7 patents, and they're no secret. You can find them in the US patent offices. Once they give it to you, they publish them. So everybody can find them. It's on the US
You have
patent.
7 patents, you say?
Yes. And so the goal here is now to get those to the patient bedside. But we set up a little biotech company, and you have to generate money. And, my goal is to do, if I still have enough time left in this world, 2 phase 1 studies, one for wounds that don't heal in scleroderma patients, those digital ulcers, and the other is for neuroregeneration. Just 2 phase 1, 10 patients each, dose escalation. And if it looks good, at that point, I think I'll be where I'd like to turn this over to others.
Right.
But, I know you think, oh, you can get this done in a year or 2 years. That's not true. Everything takes longer. 35 years ago, or 30 or whatever, I had the idea of stem cell transplant for MS, and I was young and I thought I'd have all the answers in 5 years, and here we are now. So fortunately, it is moving forward, and we've had some really great results, and I'm seeing now patients 10, 15, 20 years out in all 5 of these diseases in remission, no drugs, doing great. And it needs to continue on, and my goal in the medical textbook, the publications I've written, the talks I give, and this lay book is to help make sure it goes on. It's my first child. Now it's in its teenage years, but I want it to grow up right in the teenage years and not get corrupted. And, I have a passion for it. I want to go forward, but I need to develop this other area. And, that means I'm not going to be able to be 24/7 like I always was for the autoimmune world, but I'll see that it keeps going forward and play a role in it. It's a passion, it's love for me, but I want to get these IPS going. And again, it's basically starting a mini biotech company is what we've done. So, and it's a whole nother set of problems, and it keeps you young Even writing a patent is a whole nother way to write. Just like writing a medical or science paper is so much different than writing this, which is more humanities, and I loved it. Writing a patent is a whole nother crazy way of writing that takes time to learn how to do, and also extremely boring.
Is there a world out there where Chicago will once again be offering HSCT to patients in the United States or beyond?
No, I will be offering HSCT at Scripps in La Jolla. And if you want it with
I'm
me,
sorry, in Scripps where?
La Jolla, it's north of San Diego.
Okay.
Yeah, and so if you want it with me or people working with me, you can come there. But I have gears turning, and there are reasons for that. I'm here in Chicago now, and I commute back and forth, but the Chicago is for the IPS aspect of things. I hope down the line to stop so much commuting, but again, this is a little bit out of my hands. I have to wait for gears to turn.
So let's say there are patients out there today, or whenever they hear this podcast, and they're like, oh my gosh, I think this is the answer for me. HSCT is the answer. I really need to look into this. Where would you recommend them to go? Of all the choices all over the world, where would you say, go here, start here?
If the patient wants myeloablative, there are many centers in America doing myeloablative, and they can go to them. But if they want non-myeloablative, they can come to Scripps in La Jolla, just north of San Diego. It's a beautiful hospital. It's right on the beach. Rooms that look out over the Pacific Ocean unobstructed. So.
And that's SCRIPPS?
Yes, SCRIPPS. Like you've heard of Scripps Oceanography.
Right.
There's several Scripps, but they're all kind of Scripps. Yeah, if they want.
Wonderful. Jody, you have any questions for Dr. Burt?
I did have a question, because I know, talking to certain neurologists in Canada, obviously part of there's a very small sect of people that qualify for stem cells. And there's that kind of bridge where you can start out at RRMS, but then you come to a certain point and you're labeled SPMS, and the doctors can sometimes write you off. And so what does someone with SPMS do at that point? Like, say whether it's in Canada or whether, at your clinic at one point you said, this is not the course for you to do HSCT. What is coming up, or what could they do as opposed to just laying down and dying, basically?
Yeah, so for active secondary progressive, I will offer HSCT. It's built in the protocol that is now active. I wished I would have gotten to them before that, but because it can still have some benefit there, we would do it. When it's non-active, late secondary progressive, non-active secondary progressive, or late secondary, no, I won't do it. And there's a caveat to that. It gets a little more complicated than I think we should go into here. But in terms of your question of what to do for secondary progressive MS, I think that's where you really need neuroregenerative therapy. That's what my IPS work is. Now, it can regenerate any organ system, but certainly one of them is neuroregeneration. And as I said, I want to get 2 phase 1 studies eventually.
That's exciting.
One for these wounds that don't heal in scleroderma patients. I mean, even after transplant, the skin gets better, lungs get better, they get better, quality of life better, but they can still get they still have renounced, and they still get these non-healing ulcers. And I think that'll be very effective. I don't know, we'll just have to try. And the other would be for neuroregeneration. Certainly, I haven't yet defined where we would do that. There's, again, a lot of things we have to do. You have to do one step after another, but certainly secondary progressive or primary progressive MS could be indications for something like that.
Well, that's encouraging too. There's something coming
But
up.
that's the future.
Yeah.
Right.
And again, my mind's ready to go there, but you have to jump all these hoops, and run these marathons before you can get there. And then the data is what the data is. And
Right.
hopefully it'll be what the animal data is showing, which is awesome. Like had happened, the animal data when I was doing EAE, an animal model for MS for early or relapsing EAE, worked great. For progressive EAE, it didn't work, and that held up in humans. So we'll, but again, there's no guarantee until we do it.
I have one more question before we let you go, and we really appreciate the time that you're taking to speak with us. And this is kind of backtracking a little. What do you say to a post-HSCT patient who has been successfully transplanted? Let's say it's 5 years down the road. They get sinusitis, they get a UTI, they get the flu, all of their MS symptoms flare. Like they haven't had a single thing in all these years, but they haven't been sick either, or had an infection of any kind. They have an infection, their symptoms flare up, they panic. Oh my gosh, I'm relapsing, blah, blah, blah. Meanwhile, if they just waited a few weeks, that could subside. What are your thoughts on that? Is there anything that you can say to those patients who are like, oh my gosh, I'm relapsing, to kind of talk them off the ledge as to what might be happening?
Well, that scenario is not at all uncommon.
Right.
And those are almost always, but not always, almost always pseudo-flares. In other words, any infection, any fever, even stress, like marital stress or stress at work, can cause pseudo-flares. So, but if they're having significant symptoms, of course, we, even though suspecting a pseudo-flare by what they're saying, would ask them to get an MRI. If there's no new lesions or inflammation or enhancement, that's reassuring. It's just a pseudo-flare, as well as, if it's a UTI, you take the antibiotics or whatever, and then as that goes away, the pseudo-flare resolves. So those aren't real acute attacks. Basically, once the central nervous system has been injured, which MS does, it's more sensitive. And, fever, infections, significant emotional or life stress can bring those symptoms back out. But that's true whatever the damaged central nervous system. So for instance, if you talk to a person who's had a laminectomy, where they had a disc slip in the lower spine, and the surgeon went in and cut the disc out and released the pressure, it's not uncommon, when they have significant emotional stress or infections or whatever, that pain comes back and they have to rest and let it go away. But if you do another MRI or CT scan, there's no new slipped disc. It's just, it goes away as the stress goes away. And so that's common in people who've had slipped discs in surgery. And, once they're 10, 15, 20 years out from that, then that emotional stress doesn't seem to aggravate those symptoms like it did early on. And I think that's true with MS, that those stressors, as time goes on further, won't aggravate it as much. You won't be as impacted by these pseudo-flares. So basically, we reassure people that, 95% of the time it's a pseudo-flare, but, if they were having symptoms that are significant, or they're really worried, we get an MRI and make sure that there is no new lesions or no enhancement, which, really.
That is wonderful information, because I've heard that a million times over the last 10 years. Oh my gosh, I'm relapsing, it's over, it didn't work. When in fact, they just need to ride out the infection. Obviously, if, 2 months later, they're still in the same situation, as you said, they need to consider an MRI.
Or significant symptoms with it up front. I mean, I don't want people being worried and scared, and we'll do it. And a lot of times, when you talk to them and say this is common and the symptoms aren't that strong, then they're okay and they can wait and they see it gets better. But obviously, if they're stressed, I don't want them to continue to be stressed, and we'll get the answer with the MRI. But also treat the infection, tell them that's most likely it. And very rarely it is a relapse, but usually it's not. The vast majority of the time it's not. It's a pseudo-flare, which is frustrating. So I tell patients when they go out there, if that happens, don't go to your neurologist, because I've seen them go to neurologists say it's a flare and they start steroids. Well, then you can't do the
Yes.
MRI because it hides the inflammation and you don't never really know. So, and then because they said that, you have to count it as a relapse, but there's no documentation it was, and it sounds like it was just a pseudo-flare. So we have
Right.
to caution patients, the first person you call is us. I mean, of course, if you can't walk, you go to the emergency room and have the emergency room doctor call. But that also means you have to be able to answer the phone at 2 a.m. for an emergency room and stuff like that. And
Right.
so I have to go down this IPS path, which is a whole amount of other time. And you know, like I said earlier, to get really good at something, you have to focus on it. And so
Right.
now, yeah, I got really good at transplant for autoimmune disease because I stopped transplanting cancers and leukemias totally and focused on it. And really, that's what I need to do with IPS. But because of my
Yeah.
love for this that I started in, because I feel it's not going in the right direction with these myeloablative regimens, because I still hear so much things that are just not accurate out there, including from physicians. You know, I wanted to get these publications out, and I want to see, I will still be seeing patients go forward, but I've got to make the IPS work. And, you know, if push comes to shove, I'm going to have to make a selection, but I'll do the best I can.
I know, I'm excited. Trust me, there are tons of patients out there just like us who still have damage from MS. Even though, you know, our disease has been halted, wouldn't we love to see some reversal, even if a little? So, and just, you know, spinal cord injuries, organ regeneration or repair, that's exciting stuff, like very exciting. So
Well, it's kind
we
of where I
applaud
was.
you.
It's where I was 30 years ago with autoimmune diseases. So after 30 years, I'm right back where I started.
So how cool is that?
Well, it keeps you young.
Yes. Well, thank you so much for coming on. I'm hoping your assistant or someone can provide us with a link to scripts.
If you will email me, you can use my university email that you always have, because I have both.
Okay.
I will forward that link to you.
Of course, we're going to have links to the book,
Yes.
so
then-
people can purchase it.
We also set up a website to inform people. It's called astemcelljourney.com.
Oh, cool.
So links to
astemcelljourney.com.
tons of data in there, and all my publications are there. So, you know, if you're not part of a university, you can't get a university library, you can go to my link and get it.
Yeah.
Yeah, I don't put other people's papers, just mine. But
Yeah.
anyway, so it's all one word, astemcelljourney.com. And lots of information there, videos, everything. So link that as well. Email me and I'll follow up with what
Wonderful.
you're requesting.
And I highly recommend the book to anybody who's considering HSCT or anybody who's had HSCT. It's just so interesting to see how it all evolved from the
I
get-go.
actually think anybody with an autoimmune disease, and more importantly, anybody in the healthcare profession, whether business or medical or nurse, or a phlebotomist or whatever, or technologist or whatever they are, or anybody interested in healthcare policy in the direction of our country, I think you'll really enjoy this book. And so it's just making people aware of it so that they read it. And everybody who has read it has been shocked that I wrote it, you know, in a pleasant way.
I loved it.
You can
Loved
write
it. Your how you were open about everything. There's nothing you didn't touch on.
Well, I don't talk about personal animosity. Everybody has that in their career, but that's irrelevant. I talk about systematic problems with it as well as the development of the field. But I've had people, when they read it, ask me, so who's the ghostwriter? Well, thank you very much for your confidence in me. So, but it was much fun to write. It really was. And it was, every patient that I worked with, they were so phenomenally great and enthusiastic about it. And I did ask the patients to try not to say anything till it comes out. because other patients would be asking me to be a part of it, and because of the limitations and the size, I can't do that, and then that would be a horrible situation to say no to someone. But it's out there now, and I'm really glad I did it and had the opportunity to do it. But it's important that people read it, and it's important also for healthcare.
Yeah.
And in fact,
As a whole.
a chief of staff in the U.S. Congress has figured it out. He's read it. And he's going to give one book to every U.S. congressman and U.S. senator. So, you know, because I think if you read the last chapter and you read through it, I mean, there needs to be changes in our healthcare system. And this outlines some tweaks that are important to make the patient first. But you know, the system is obviously very big and self-entrenched, and it, you know, I don't know if it can change easily, but you know, change has to occur. You know, just the fact how people have to fight and what they have to go through, how even after you do better, you go back to a neurologist and tells you this was the wrong thing, and you know, fighting with insurance companies and so forth. It's kind of crazy. It's not working. You know, the system exists for the patient, but a lot of the patients find it's not working for them, and they have to fight and fight and fight for themselves, even fight to find out about this. So when it really exists. And so, you know, for me, I also mentioned like some of the frustrations when you know you can help someone and you can't because the system is working against you, although no one's intentionally being malevolent. But, you know, I bring out ways to tweak the system that could benefit the patients and benefit the field, that hopefully people who, whether they're lawyers or legal or legislative or whatever, can start to pick up on, and that, you know, carry the ball forward on that end of things.
Basically, I think you were saying, trying to bring forth how we need to be as patient-centric as we are profit-centric.
We need to be first and foremost patient-centric. Now, a physician is pulled away from that when he's an employee who has to satisfy the rules and the money and the expectation of the employer.
Yeah.
And that needs to change. There are 4 states in America that don't allow hospitals to own physicians. That's a very wise thing, and I hope that catches on. But, you know, we need to make it so that physicians' own finances and career isn't in jeopardy by being able to dig in and fight for his patient against the system, which when you're employees doesn't, it becomes impossible to do that or to take it very far. So hopefully you need an advocate that's free to advocate for you. Like, as I said, when you go to get a lawyer, if you need one, God forbid, but if you need one, you don't want a lawyer working for the district attorney who's trying to prosecute you, or for the prosecuting attorney who's coming after you. Obviously, he's not going to be able to really fairly represent you, no matter what he says, because his paycheck's coming from them. So, you know, medicine is a profession. Healthcare is a business. You need an independent representative to bridge that gap to help you, not only for your medical and psychological care, but for financial care as well, and understands that. And that's what's missing in our field. It's just the way the system is developed and has continued to expand and feed on itself, where everybody's in their own silos, but the patients are being lost as to what, that's why the system in these silos have developed. So I bring that out in the last chapter.
Yeah, I loved it. So, Dr. Burt, thank you so much for coming on.
Thank you.
We will let you know when the podcast is coming out. It will be within the month, hopefully within a couple of weeks.
And me the web address for it?
I'm sorry, what's that?
This podcast will be on YouTube, yes?
Yes, it's going to be on
Sure.
YouTube and it's going to be on several other Instagram, everywhere.
So send me the YouTube address,
Yes,
because what I'll do is I'll put it on my A stem cell journey and link it.
wonderful, wonderful.
So, okay,
We will do that.
all right. Thank you
You
so
have a
much.
wonderful rest of your day.
All right, thank you. Any more questions? And, if you ever have
Jody?
questions down the line, feel free to just email me. You also have my personal email, but don't give that out. I think, don't you have my
Will
personal
not do
email?
that.
I'm
Can
not
you
sure.
imagine?
I'm not sure if you do or not. Maybe you only have the one university email.
I have your assistant's, I
Okay,
think I have your assistant's email address.
okay, good. Yeah,
Yes,
she can always.
yes. Jody, anything else?
I have a burning personal question, but it's probably not the avenue to talk about it. So,
Yes, I'm actually, despite what I wrote in here, I'm a very private, person with some introverted tendencies.
oh, okay.
So yeah, I tend not to go down that road.
Oh, sorry. I meant for myself.
Oh, no, I'll be
As-
glad to
sorry,
help.
I meant for a specific question for my own history. But I respect that you're
But
very
let's
good
do
at
that where you're not on a camera, so that it stays confidential for you.
Oh, okay.
Yeah.
Good.
So I'll follow up
Okay,
with you. I'll give you my cell if you want to call.
Okay, perfect.
There you go.
Thank
How's
you.
that? Thank you so much. Take care.
Thank
Okay,
you.
bye.
Bye-bye.
Bye.